Dr. Pranita Sahay, who is a postgraduate and senior resident from Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi. And she is currently working as assistant professor at Guru Nanak Eye Center, Maulana Medical College, New Delhi. She'll be telling us about the general principles of surgical repair of traumatic scleral wounds. Now, it is important that it is a prerequisite for any further vitreoretinal intervention is a good surgical closure of the traumatic wound. So she'll tell us how to go about it. Over to you, Dr. Pranita.
Thank you for that introduction. Can I have the slides, please? Okay. Good morning, everybody. I'm Dr. Pranita Sahay. And at the outset, I would like to thank AIOS for accepting this instruction course and Dr. Devesh for making me a part of this. So I'll be talking about general principles of surgical repair of traumatic scleral wounds. So trauma can occur at any settings. It can be during daily activities, sports injury, assault, industrial injuries. So taking a comprehensive history before you proceed for examination and management is important because most of these patients are medico-legal cases, potential medico-legal cases. Now, moving on to our specific topic, first it is important to understand the various zones of injury. So the ocular trauma classification system has classified 3 zones, zone 1, 2, and 3. For closed globe, zone 1 is the bulbar conjunctiva, sclera, and cornea, and anything up to the posterior lens capsule is zone 2, and beyond that is zone 3. While for open globe, injuries pertaining to the cornea and limbus is zone 1, and those extending from limbus up to 5 mm of the sclera is zone 2, and beyond that is your zone 3. So now your traumatic scleral wounds can be either occult scleral perforation, a combination of corneoscleral perforation, or limbus to limbus corneal perforation with scleral perf extending on either sides. In blunt injury, the site of scleral perforation is usually where the sclera is weakest, that is near your insertion of the muscle recti or around the optic nerve. These sites are often difficult to approach and therefore difficult to manage. Now, the evaluation is obviously common to all cases of trauma. You assess the vision, do a slit lamp test, sedal test, fundus evaluation. If the fundus is not visible, you do an ultrasound. And X-ray is mandatory in all cases to rule out intraocular foreign bodies. CT may be done based on case-to-case scenario. So, achieving the anatomical integrity is your first target, and you also want a good functional outcome, but it is obviously your secondary aim. Now, to repair, first you need to have a good exposure of the site, you need to do a good conjunctival peritomy and restore the anatomical relationship, which first starts at the limbus, and then you move posteriorly from limbus posteriorly into the sclera. Any prolapsed vitreous needs to be excised, and the uveal tissue, if it's a fresh injury, can be reposited, but if it is an old injury or suspicious of infection, needs to be excised. In case it is extending beyond your recti, you need to first disinsert the rectus muscle, repair the sclera, and then reinsert the muscle. Post-operative management, topical steroid, antibiotics, cycloplegic. Important here is oral steroids because these are patients who are at risk for sympathetic ophthalmitis. So initial few days or few weeks of oral steroid is essential. So let's go on to a video-based discussion. This was the first case, a 28-year-old male who presented with workplace injury with an iron blade 2 days ago. He had a vision of 6x, IOP of 12. And on close examination, what you see is a bluish hue at a region around 4 to 5 mm from the limbus. Now, this looks like an occult scleral perf. Hence, what you need to do is go on for a globe exploration. Pre-operatively, we did a fundus evaluation. The posterior segment, posterior pole looked normal. However, in the periphery, there was a focal vitreous hemorrhage with retinal bleed. So let's go on to this video. So this patient was taken under subtenon block because GA was not available. Patient was cooperative. So we did a focal peritomy away from the site of the perforation. It was an infranasal peritomy was done, and focal tenotomy is being done, and a channel is being created wherein through a 27 gauge cannula, xylocaine was injected. Now, if possible, the best ideal condition is that you take up such patients under general anesthesia, but however, that may not be always available outside institutional setup. So you can even take up these patients under peribulbar and subtenon blocks. A focal peritomy is done over the site of the occult perforation. You need to lift up the conjunctiva and dissect it and cut it so that you do not damage the underlying uveal or scleral tissue. You need to clear up the tenon so that the suturing is easy. With the help of a cotton bud or Merocil sponge, you need to check the site for any vitreous prolapse. If present, it needs to be cut. And your assistant needs to constantly clear up the site so that when you're passing the needle to repair the sclera, you should be able to see the needle so that you do not inadvertently take up any uveal tissue in your suture, in your needle track. So you need to continuously, the assistant needs to mop it. The repair here is being done with a 6-0 vicryl suture. The suture needle is passed through the partial thickness of sclera, and any undue pressure on the sclera or the wound should be avoided as it can increase the risk of vitreous prolapse. And after tying the knots, the suture is cut. You should at least leave 1 to 2 millimeter of the suture end behind, because unlike the 10-0 sutures, these suture knots tend to open up and slip away. So tight knots and leave at least 1 to 2 millimeter of the suture end at this point. Now the second suture bite is being done and suture is being tied. Following this, since a retina surgeon was available operating on the other table, I asked my colleague to have a look intraoperatively. And since there was a focal area of suspicious retinal area where they were suspecting a retinal break, that area was intraoperative cryo was done at the posterior edge of the scleral perforation. Following this, the peritomy was closed with interrupted sutures of 8-0 vicryl. These are the post-operative pictures where you can see the wound is well opposed. The patient maintained a visual acuity of 6-6, but what is important is to follow these patients up very closely because retinal breaks and retinal detachments are common, so close observation is essential. This is the second case. It is a 45-year-old male who presented with trauma due to fall 5 days back, presented with a vision of hand movement close to face, open globe injury, corneal scleral perf involving zone 1, 2, and 3, flat anterior chamber, and cataract. Fundus was obviously not visible due to cataract. We did an ultrasound. Fortunately, patient did not have a retinal detachment, but there was a choroidal detachment, which obviously can be there in patients because of the hypotony. So let's have a look on how to repair cases of corneal scleral perforation. As we already discussed, the first suture that we need to pass in these patients is at the limbus, because that is what demarcates your cornea and sclera. You don't want post-operative zigzag appearing limbus. So the first suture was passed at the limbus and a 10-0 monofilament. Now a judicious conjunctival peritomy is being done to expose your scleral perf. Now we don't want to expose the scleral perforation completely. First we start repairing as much as we see. The first scleral suture is close to the limbus and then you extend posteriorly. Suture bites partial thickness with 6-0 vicryl interrupted, avoiding the uveal tissue. Following this, it is essential that after passing every suture with a Merocil VEC, you can check for the vitreous loss, and the vitreous strands need to be cut with the help of Varnas, and then you can continue with your suturing. Here you can very clearly see that the needle was very well visible. There was no uveal tissue in the suture. Now you can further expose the scleral wound now, and it is important to visualize the posterior extent of the scleral perforation so that you have a complete repair of the scleral laceration. Now we moved on to the repair of the corneal perforation. A side port entry was made and air was injected, followed with pilocarpine injection. And since this was an old injury, 5-day-old injury, we excised the prolapsed uveal tissue, following which the chamber was again reformed with air. Sometimes it may be difficult and you may need to inject viscoelastic agent to form the anterior chamber. And following this, the corneal perf repair can be proceeded. The first suture on the cornea has to be at the 50-50 junction of your corneal perforation, following which you divide the perforation into equal parts and put in interrupted sutures. The peripheral sutures have to be long and the central sutures toward the center of the cornea are short. And this is how you proceed with interrupted suturing with 10-0 monofilament. And later on, suture adjustments can be done if they are tight or loose. Then you do a BSS wash and close the side port as well with 10-0 monofilament. The conjunctival suturing needs to be done very carefully. Sometimes the conjunctiva tends to retract post-operatively. Hence, sufficient numbers of sutures need to be put and they need to be repaired carefully. So this is the post-operative picture. The anterior chamber was well formed and the cornea wound was well opposed. And the fundus needs to be evaluated again very carefully in these patients. If needed, if there are any breaks, a laser can be done, as was done in this case 3. This was a patient who presented with scleral perf in zone 1 and zone 2. In post-operative period, there was a suspected retinal break, and laser delimitation was done post-operatively in this case to avoid development of risk of retinal detachment. Whenever you're operating such patients, patient will always ask you for their prognosis. Hence, you need to know the ocular trauma score. On the basis of this scoring system, you can calculate a score and tell the patient what their 6-month likely visual outcome is going to be. The various complications that these patients can have can be wound related. You can have wound leak, conjunctival retraction, suture infiltrate, vitreous prolapse. In the left top, you can see this is not an ideal repaired perforation. The limbus was not opposed very well, and you had a zigzag limbus, which is not what you want. You start your repair from limbus, you will not have a post-op like this. Posterior segment complications can be endo, vitreous hemorrhage, choroidal rupture, traumatic uveitis, or choroidal detachment. I think everything will be covered in the later sections. And other complications can be PANOF, sympathetic ophthalmitis, and phthisis bulbi. So the take-home message is, take a detailed history, do a good clinical examination, meticulous surgery with a proper exposure of the wound, and anatomical landmarks need to be identified and opposed, and avoid vitreous loss and repair from limbus posteriorly, and careful evaluation of the retina in the post-op and a careful follow-up is very essential in these cases. Thank you.
Thank you, Dr. Pranita, for the wonderful talk and the beautiful videos demonstrating the principles of surgical repair of scleral wounds. For the completion's sake, Dr. Ramanuj, what would be your take on the role of prophylactic cryotherapy in traumatic scleral wounds involving zone 3?
So I don't do prophylactic cryo in all patients. If the media is visible, I would like to take a look at the posterior segment, because cryo, again, if there is later on detachment, there will be higher chance of PVR. So if possible, I would prefer LIO rather than cryo. So, but sometimes if you see an obvious break, the media is here. In that limited scenario, I will do cryo, but I would try to avoid cryo if there is no obvious break.
So now there is a recently we have good enough evidence that cryo may not be a suitable thing to do in open globe injuries involving the zone 3, because it can further precipitate inflammation and increase the risk of PVR. Quickly, next question to Dr. Simar, whether you would like to highlight the role of oral steroids and oral antibiotics in such cases?
So definitely, as a protocol at PGI for all our open globe injury cases, we do give 5 days of IV antibiotics, oral steroids once we have ruled out fungal infection in the eye with a vitreous tab that we take at the time of repair. And we do give intravitreal vanco and Cefta at the time of repair.